By request of the meeting organizer, this meeting is being recorded.
Quality Center, and I'm pleased to welcome you to our December 2nd End Disparities Learning Exchange office hours entitled Developing and Maintaining Local Teams. Before we get started, normally we like people to enter this information within the chat room, but I think that we're a small enough group that we can just kind of go through and introduce ourselves one by one and say where we're calling from. That way we have a sense of, what we have in store for us on today's office hours discussion. So I'll start again. I'm Michael Hager. I'm with the National Quality Center in New York, and I am the lead for the End Disparities Learning Exchange. Who wants to go next?
This is Judy. Hi, I'm Judy Popkin. I'm the National Quality Center coach, and I cover Florida and Georgia. And thank you for having me.
Great. Thanks for joining us.
And I'm Nanette Bray-Magnani, and I'm also a coach and cover Massachusetts, Eastern Pennsylvania, Chicago, Mississippi, and Louisiana, and I'll be facilitating with Michael today.
Thank you so much for helping me out today, Nanette. Your wealth of experience in working with grantees or recipients of all parts funding across our big country comes in very handy, and you're a wonderful resource to have with everyone on the line today. So thank you so much for agreeing to co-facilitate or facilitating.
You're welcome. It's a pleasure.
Who wants to go next?
I'll go, Michael. This is Chuck Colasar. I'm the Program and Quality Manager at the Ryan White Part A in Memphis.
Welcome, Chuck.
Thank you.
My name is Tony. I am with the College of Medicine in Peoria. We have an HIV/AIDS clinic. I'm the office administrator, just getting started in our CQI program.
Welcome.
Thank you.
This is Robert Bobo. Can you hear me?
Yes, sir.
Okay, and I am in transplant to Community AIDS Network of Florida. We have 24 clinics throughout the state, and I'm the QA/QI specialist. I guess it's a new job.
Welcome, and thanks so much for joining us, sir. Is there anyone else on the line who wants to introduce themselves?
Hi, everyone. My name is Emily Chen, and I'm with the National Quality Center as a program fellow, and I help Michael out with a lot of the logistics and planning behind the Learning Exchange.
Thanks for joining us today, Emily. And is that Christine from California?
Yes, that's me. Hi, Michael. This is Christine Kiburi, a clinical quality management nurse for California's Ryan White Part B program.
Great. And last but not least, from what I see, Julie, would you like to introduce yourself?
Julie Baker with the Iowa Primary Care Association.
Welcome. Some Heartland, great. A couple of Heartland folks. Well, thanks again for joining us. It's good to see that we have a range of folks who are likely going to define teams in different ways. So we have a good discussion today, and we hope that you all get a lot out of it and that you have some questions and some concerns that you want to bounce around with your colleagues across the country. Just as a reminder, and for those of you who are watching the recording who may not have picked this up before, the End Disparities Learning Exchange is a 9-month initiative that promotes application of improvement interventions to reduce HIV-related disparities in 4 key subpopulations. We're doing this while building and sustaining a community of learners across Ryan White HIV/AIDS program recipients across the United States. The Learning Exchange offers a number of informational opportunities by content experts and utilizes the power of peer learning to facilitate local improvement efforts on eliminating HIV-related disparities. And this webinar is part of those educational opportunities. It's in office hours, and we'll talk a little bit more about the various opportunities we have through the exchange momentarily. In case you've missed it, the End Disparities Learning Exchange video is a wonderful promotional tool to spread awareness about this initiative and the importance of tackling disparities in HIV health outcomes. It's available on our YouTube channel, but you can also access it easily by going to our website, www.enddisparities.org. end+disparities.exchange.org. So office hours are on Fridays at 1 p.m. It's almost every Friday, but it's a variable schedule. So we ask that you check out our calendar and our social media posts about specific office hours and content that might be of interest to you. No registration is required, and it's open to everyone, regardless of direct or indirect Ryan White HIV/AIDS program funding, or whether you're a consumer, provider, policymaker. Pretty much the idea is that anyone who's interested in talking about HIV health disparities and working on solving them is welcome to join these webinars. We're trying to create an open-ended dialogue that explores specific topics, and so we really encourage you to be
Your recording has reached the maximum length. To replay your message, press 1. To delete and re-record your message, press 3. For delivery options, press 4.
Okay, sorry about that, my friends. I went ahead and muted the line that was giving us the voicemail response. But basically, the short and skinny is that we're hoping that you have lots of questions and you take advantage of the opportunity to interact. Today's topic is developing and maintaining local teams to tackle disparities in our communities. So as I mentioned, or as we mentioned at the beginning of the call, we have on the line today Nanette Braymagnani, who is a very seasoned NQC coach. She's been working with NQC before NQC was NQC. And has a great deal of experience working with folks from all over the country at all different levels, and is an expert in terms of thinking about team building and community-level activities. So with that, I'm pleased to turn it over to Nanette to lead the conversation for the next hour. Nanette?
Thank you, Michael. And welcome to everybody who's on the call today. It's a rather small group, but each of you bring a unique situation. So it's really great to see a range of a network, a Part A, a Part B, folks from across the country, and new people and people with quite a bit of experience. So I think that, as Michael said, the intent of today's time is really for you to help us tailor the conversation based on what your needs are. So that could be either teams or groups that you're working with that is face-to-face, or it could be, as that top picture depicts, is a virtual group if you are trying to bring in different teams from different agencies that might go either across your Part A program or across your state or across your region. And I think with all of us on the call, we'll be able to share, what works and what some of the issues are, and we can help problem solve together. So Michael and I really don't know what you want to talk about, and so we just have a couple of teasers in terms of questions that you could introduce yourself, give us a little bit of a background about who you're working with, what teams are you already established and that you already have groups, so that when you're thinking about doing your data analysis or based on your disparities results, that you already know who you're working with. You might want to check out whether or not the folks that you have on that group are the right ones. Do you think you should be adding others? Who's on, are the people who are members of your team the ones that are also going to be making decisions on what the priorities will be in terms of what your next steps be to work, what subpopulation or more than one subpopulation? Will there be a variation across the groups you might work with? And will these folks be the same ones that will be expected to do the QI project if there are true disparities found within your data analysis? So I'd like to just throw that open and have one of you just kind of take the lead and jump in there and tell us what's going on with the work that you're doing. Chuck, could I ask you to be our first person up?
Sure.
Since you're working with Memphis Part A, yeah, what do you have established groups that you're working with, and are they working well as a team, and are you going to use them to take a look at the disparity data and analyze it and decide on priorities. Tell us your thoughts.
Sure. So I've presented the disparities calculator in a couple of different places. One was with the Quality Management Committee, and then I also presented it to the Planning Council, which was really interesting to get their feedback as well. With our disparity locally, especially along the lines of viral suppression, we know that we have issues with transgender individuals as well as with our youth. They were both highlighted as pretty significant disparities along the lines of viral suppression. So we're really kind of trying to focus on those two groups right now. We at the Quality Management Committee, we do not have any transgender folks at the time. We did have a young lady that was a part of that committee, but she has dropped off. So we definitely recognize that as an area where we need to recruit more folks. Just last night, another community group we have going here is called the Kumbaya Coalition. Basically, it's all the providers have decided to come together and work together on a World AIDS Day celebration. So we did that last night, and there were several transgender individuals that came to that celebration. So I approached them and invited them to come to the Quality Management Committee and try to get their feedback, and they were all really excited about that. So we're happy about that. Surprisingly, it's kind of harder to find youth, young people that want to get involved in the quality improvement. I have one young man that works with other youth in one of the community service organizations locally, and I've recruited him. In fact, we're planning to come to the consumer training here shortly. But so that's kind of how we're doing it. We recognize that we definitely need that input on our quality improvement committee from those individuals that are experienced, in those subpopulations. So that's kind of our starting point at this time.
Okay, and Chuck, do you have any questions that you might have for the group so that they could give you some ideas or input, or do you feel like is your process fairly well thought out in terms of who, maybe you could help us better understand who would be working to improve those populations of viral load suppression?
Yeah, so our Quality Management Committee is made up of, we have a good, pretty much representation from all the different providers. So once we went through the disparity data, and they recognized, where we're kind of falling short across the TGA, I've asked them to individually try to come up with some ideas about how they can improve access and service within their own clinics to those subpopulations that we see that are disparate. And I'm also, volunteered to come help them look at their data. We have a couple of pretty large providers that have several thousand clients that we could run the disparity calculator just for their operation, and kind of see if that's still reflective of what we've found across the TGA. But it's everyone kind of likes to do things the way they've been doing it. It's kind of hard to encourage them to change. But I think once you highlight the disparities and you highlight the issues, especially that young people are having in our community, then they realize the value of how creating some programming specifically for those folks, how useful that would be. But I guess the question for the group for me is just how to retain and engage young people. I mean, our youth seem to be just too busy to worry about getting treatment.
No less attending
anybody
meetings.
On the call? Go ahead,
Yeah.
I'm sorry.
I said no less attending meetings, trying to get them to actively participate in an assembled group. Even that group has the best intentions. I find that my clinics also have trouble at their clinic level getting, you know, the youth to participate in anything that's sort of a formal setup.
Exactly.
Does anyone have a success story around engaging youth that they'd like to share?
You know, I could say one thing. We are blessed in Memphis to have St. Jude Children's Hospital, and they do have a small HIV program there. And so they've been, I mean, they have some programs that have been pretty successful with engaging youth. However, some of the other providers, they just kind of point out that St. Jude has a lot of resources that they don't have access to. So that they kind of think that that's kind of a problem for them, but you know I encourage them to try to do whatever they can with the available resources. But it is definitely an issue, especially one of the things that we find here specifically. We have a very resource-rich environment at St. Jude, and when those kids age out in their early 20s and then they transition to adult care. You know, the adult care environment is very different from that kind of nurturing, exactly. Almost Disneyland atmosphere. So, you know, they kind of get into the adult world, and a lot of them drop out of care. So we've been trying to, work on building bridges there to help young people transition to, adult care. But it's been a challenge for us for sure.
Hi, this is Christine from California. I wanted to just echo what, was it Chuck speaking? Sorry.
Yes.
That I'm hearing from, because we're at the state level and I don't have direct contact with the clients as yet. So I rely on our contractors, and that's one thing that they're mentioning is the transition part from where they have all the resources and support and people telling them, reminding them to take meds, and then they go into adulthood and there's no that support. So a few programs are coming up with transitional case management programs.
Oh,
so
great.
Yes, I'll be talking to them to see. They're starting up, so I'll be following up with them to see what challenges they're facing or what successes they're having, and we'll be sure to share that with you.
Oh, great. That'd be very useful.
This is Judy. One of my hospitals, University of Miami and Jackson Memorial, which are connected, but again, one has the youth program, one has the adult. They also are having the case managers meet several times with the client in that transition period so that it's kind of a warm handoff, and they are going, again, from that nurturing Disney kind of environment to motor vehicles, if you will. And it too is a big leap. So they're trying to make it, more of a warm transition so that that's not the point in time that they lose them. So I guess when we get to this topic, one of our other calls and webinars, we can also talk about some of those experiences. I'll get more information.
Thanks for that point, Judy. So next week, I'd like to point out that our office hours on Friday is going to be focusing on tools and resources you can use to identify appropriate interventions for populations you're trying to serve. It's going to be a little bit more general in terms of where to find resources that could help. Our population-specific months will be January, February, March, April. And April is when we're going to be talking about youth health. And we have an amazing program and lineup of speakers, but it's in April. So, in terms of the specific population focus, we just have to, sit tight. But in terms of thinking broadly about resource sharing and all of that, that's something else that we'll be exploring on future office hours. So it's really great to hear that we're thinking about making sure that we have good engagement of these populations within our clinical quality management committees, or that they're part of a group that is receiving presentations and information on the work that we're trying to do on end disparities. And I think, an important struggle to make sure that we do have those stakeholders, you know, in those committees. One thing that I would like to point out is that the New York State Department of Health has a couple of consumer advisory councils, and one of them is for young adults, and we call it YACAC. So for the folks on the line today, I'm really happy to email out some information on our New York State YACAC. They might have some insights or some ideas, you know, to start a thread of conversation amongst you, you know, on how to identify youth that would be appropriate for this type of presentation and to sit on these types of committees.
And thank you, Michael. Chuck, this is Nanette. I have just a couple thoughts based on what you were saying, is that it seems to make sense that before you go too much further to implement your idea about using the disparity calculator with your large hospital population. Because what I found is that in part groups, or to a great extent, groups are motivated based on the degree to which they see that part of, I guess, the broader problem is part of their problem. And it might very well be that the smaller agencies really don't have much of a disparity, if any at all, and that the larger hospital population might be skewing Memphis's analysis. And so if you do apply the calculator to the hospital, you'll see the degree to which the disparity is mostly located with them, or whether or not it really is throughout all the different agencies. So I think that would make sense. And the second thought that I had is that should it be with the hospital, and if they have the most if they have the highest proportion of youth than the other sites, they might be able to pull together a focus group of youth. Because what I found across Part C and D programs particularly is that they do have a difficult time sometimes having a consumer advisory board, and it's even more difficult with youth. And it might be that you would be able to have a focus group of youth and see if you could recruit, you know, anywhere from 4 to 7 or 8 or more youth together and share this data with them and ask, you know, get their ideas in terms of what they think this data means, why do they think it's a disparity, and, you know, ideas that they might have to move further. And if you're able to pull together that kind of group, they might be willing to meet together as a group throughout the next 6 or 8 months in terms of while you're working on this particular project. Does that make any sense?
Yes, absolutely. And you're right, because in regards to the large hospital system we have here, it's kind of, you know, as they go, so the TGA goes. They probably represent at least 75–80% of the total TGA in terms of number of clients that they see. But what's interesting, though, is that they actually see much older clients. Their average age is close to 50 for their clients.
Okay.
And then the smaller clinics, like the community-based clinics that are kind of primary care type clinics, young people tend to go there because there's less of a stigma associated with those general clinics that have HIV programs within them. The big hospital program is identified specifically as a HIV specialty clinic. So we tend to see younger people in the smaller clinics. But yeah, I love the idea of a focus group. I think that'd be really useful to try to get some insight into you know, what's going on and what barriers young people can identify for us.
Yeah, and if they realize that it's a group that's going to start and end, and that it's not an ongoing commitment, they might be more likely to work with you.
Yeah, absolutely.
Okay, well, good luck. We'll look forward to hearing. Go ahead.
No, I just said thank you so much.
Sure. So is there anybody else who'd like to share with us what their thoughts are and what they hope to do and who they're working with?
Hi, this is Christine from California. So we've looked at our data now using the disparity calculator tool. So we use our ADAP data and our ARIS data. ARIS is our database for our HIV care program. And they both data showed a huge disparity in the youth. So now we're dissecting that data by, because our services are provided by contractors, we are looking at contractors that don't have viral load suppression among the youth at 80%, because that's our California goal for now. And we're going to start, the plan is to start with those contractors, start meeting with them and start discussing best practices and interventions, and continue to have an ongoing conversation. And at this point, I am planning on asking them to attend the April session.
Cool.
And we will also have a summit next year with all the providers, and we hope to have a session where we can specifically discuss about the youth disparity. So
really
it's
cool.
in the planning stage.
Hey,
and Christine, do you want to share a little bit with the group about what your data has kind of shown you? Is it is the problem spread throughout California? Is it located more in the urban areas, or also in rural areas? Tell us a little bit about your situation.
I'm still, so as I said, I'm still looking at it. I'm early dissecting stage, but it is all over California. So it's not specific to urban or rural. It's, yeah, I can't pinpoint one specific area.
Okay, great. And how do you, are your subcontractors, are they all Part C or some Part B funded as well as Part A, so they're going across the parts, or do you have individual providers that are subcontractors that you're also going to be pulling in?
Can you ask that again? Sorry.
So who are your subcontractors?
They are our mostly counties, but they also, some of them, 8 of them get Part A money, and then they also have they have their own subcontractors who also get Part C monies.
So it's similar to Florida, and which should sound familiar to
right.
Judy and Robert, in that you have a big state geographically and population-wise that's really diverse, in almost every sense of the word. And so the state has said, instead of trying to steer everything from one central location, why don't we trust our counties or our regional health districts to do this? And so you fund the counties who then fund others. So it's like a team of teams that you're working with in Sacramento, right?
Yes, absolutely. So I do have data for our the people we have, the counties is contracted with, and also I'm lucky enough to have the data now by the people they have also subcontracted with. So I can provide this data to them.
And have you done other QI improvement work through your system, or is this disparities work going to be the first kind of more formalized QI effort?
So I just started this position this year. And
okay, congratulations.
Thank you. So we haven't had a QI project in the past. Right now we are working on, there's a project that's underway on increasing extragenital gonorrhea chlamydia screening in MSM clients, but then this will be the next big project, working with the youth.
And so I'm wondering if maybe folks in Florida, do you need any tips on what has been successful for them in terms of organizing their groups within their counties, or is yours a fairly well-established process?
Absolutely. I will take all the help I can get.
Okay.
Well,
so Robert and Judy, do you have any tips for Christine?
Judy, go ahead.
We're just at the outset of having put together a statewide integrated plan and getting some consistency in not only the EMAs throughout the state and TGAs, but also at the community, local, regional planning council level. So I think just the same way that some of the local districts have done their own cascade, that this might be an interesting way to have them look further at the data by using the disparities calculator. But for me as a coach, I don't actually have direct contact with the planning councils, although you know, I have a contact person where maybe it would be a great idea for me to at least introduce them to the learning exchange so that they can decide for themselves if they want to take it on at that level. But at the very least, there are 2 Part A recipients that I know are using the calculator to look further at their data, and then they will drill down. I believe one group is going to focus on the women of color, you know, the African American and Latina women, and that's the Miami-Dade area. But I had a question for Robert, who's on the phone, representing now a community-based organization with 24 different locations, whether there's essentially like a data warehouse where you have everybody's data and then you're also able to break it out by region within the state and look at those differences and similarities.
Well, to begin with, Judy, I'm here 3 months now, and we're going to do that systematically. You taught me well when I was out at Hendry in a rural county. We're starting with the west coast of Florida, and then we're going to, as the data system allows, we're going to spread it throughout the other 2019, right? 20 sites. I mean, we're over here. But what I wanted to piggyback on what Judy said about statewide is that with the integrated plan, it was one of the glaring outcomes of our gap analysis is that a lot of the Part A's were doing QA/QI, and the Part C's. Part B had a totally different definition, and we're trying to align all the parts into. So first of all, we have to do that. And at the last statewide face-to-face meeting, there is Lorraine's putting together. She's our statewide QA/QI for Part B, putting together a subgroup of which I'm the co-chair of for statewide, that we haven't looked at our goals and objectives yet but that's be happening in a January meeting. But you know, I've been looking at this the calculator, and I'm excited about it. I have an unlocked version, so I've been putting in a whole lot of different data points. The problem with the state of Florida is with the data points in the campaign itself, and I have Tallahassee working on it, is that with the careware system that the state used doesn't parse the subpopulations out in that manner. But they're working on it along with, I think I have a help that ticket into JPROG. So, and then Michael, in a previous webinar, I think it was said that there's a pilot out there by NQC. So we're going to get there some kind of way, by hook or by crook.
And yes, we actually have a beta test of the careware extractor for the 4 main default populations after this call. So we're hoping that that beta test goes very well and that we'll have some news to share with the entire community next week. And hopefully these will be rolled out next week. So fingers crossed that it goes well. Otherwise, we might have to go back to the drawing board. But of course, we're willing to put in all the effort to make sure that this is as easy and seamless as possible for everyone who's doing it in the communities.
So, Christine, I pulled out a couple comments from what Robert and Judy were saying, and I just wanted to touch base with you that Robert mentioned using the unlocked version of the calculator. Not just Christine, but are other folks on the call, are you aware of it, and do you know what it is?
Yes, I got, Michael did send me the unlocked version because our office was interested in using the tools to expand the populations so that we can use it. It will help us address our identified populations in our integrated plan. So yes, I'm aware of it.
Okay, and then I think a couple ideas that came out was that is Part B going to serve as kind of a warehouse of data for the different regions and programs? So are you going to be analyzing the data so that you can feed it out to each of your subcontractors? And are you going to be doing it regionally, or will you be giving the calculator to, let's say, some larger programs and having them analyze their data?
Currently, I'm doing the data analysis as a using the statewide data. Then, since it showed us the disparities in the use, then we decided to focus on the use, and I break down the data per region or per contractor, if that makes sense.
Okay. And I think it does. And I think one of the other ideas, I believe that Robert said that they were starting out in one of the locations first. And I think an idea to consider is that if you have some programs that might be more likely to engage in QI initiatives or are more interested than maybe other regions, that you might think about working with them more closely so that they can serve as a model as well as have ideas to then share with other parts of the state that might be more reluctant. So that might be an idea to consider.
Yeah, great idea. Thank you.
This is Judy. I just have a question, but I was just wondering if our federal partners, and those project officers that have responsibility for Part B programs have also been encouraged to kind of start at the state level and see if, who's interested and if they have the capability to slice and dice some of the data using the calculator and then send it out to, regions or EMAs and so forth, because that sounds like an awesome way to filter down some great data.
Yeah, our federal partners are very supportive of the end-disparities learning exchange, and each project officer has a different set of priorities and prerogatives with their recipients. So I know that there's a little bit of nuance and flavor that happens there, but I think it's a wonderful suggestion. Michael Goldrosen, the director of state HIV AIDS programs, DSHAP, so basically he's in charge of all the Part Bs, is someone who, perhaps we should consider reaching out to make sure that, he's aware that some states are doing this and that there might be interest in creating a discussion group, and that the POs might want to be involved in that. That's a great idea.
Okay.
And Robert, were you also wanting to say something, or was it Chuck or somebody else?
Yeah, no, I let my coach go ahead. She's a wonderful woman. And Judy, you need to pay me for saying that.
Thank you, Robert.
Is that one of the things that, being coming from a rural setting, before I came here to Ken, is that a lot of the times when we were asked to do stuff from central office in Tallahassee, is that we didn't have the resources. So my approach, another approach that in such a large state like California, you may have different areas, pockets that don't have resources. Most of the state of Florida, contrary to people's belief, is rural. And so therefore, you know, I came here, we're going to use the site that's closest to my home, first of all. Secondly is that it has the smallest staff, and we're going to try to use that as a model. Sometimes, you know, when you have a smaller group, it's easier to work with than a larger group with a lot of reresources.
That's part of our motto is start small, right?
Okay, that's all I had to say.
All right, well, thank you very much. Comments or questions from other folks who are on the call? And I was wondering, Deanna, would you like to introduce yourself since you've joined the call after folks had already introduced themselves?
Hopefully you can hear me. I had a problem on yesterday's webinar.
We can hear you.
Yay. I'm with State of Oregon Part B, which is the balance of states here in the state of Oregon. And thank you for continually supporting the Learning Collaborative by having these office hours. I just am appreciating hearing what other people are doing because we just completed our HRSA site visit. So now I'm getting ready to ramp up to now move forward with this Learning Collaborative.
Deanna, thank you. Have you had an opportunity to use the calculator?
Our data IT specialist in surveillance has, and he has done some of the preliminary data. We had some challenges with the calculator, and so I had just asked Michael if I could get the unlocked version. I think that will probably help some of the issues he was having with it. So at this point, we don't see a lot of disparities because we don't have huge numbers anyway overall. So we're in the process then of just looking at the small numbers we do have and seeing if there's somewhere to move forward, even if there's slight disparities.
Okay, good.
And Deanna and Chuck, loud and clear, I got your request. I'll be sending you the unlocked version of the tool probably after the beta test is completed for Careware. And, you know, as always, I'm very accessible as long as I'm in the office. And if you would like to have any conversations or go over questions one-on-one, or if any team members have questions, just feel free to drop a line or reach out and give me a buzz, and I'll be happy to answer all those for you.
Thanks, Michael.
Absolutely.
So just a quick Careware question, if I may.
Sure.
So Michael, you just responded to my question to you because I was a little confused about the Careware beta testing part because I wasn't on the last office call for one, so I don't know, you may have mentioned it before, so thank you for clarifying. But I'm just curious, if everything goes well, is this going to be part of the new Careware build, or do you know?
I think I'm not sure. I'm not a Careware expert myself. I think that this is going to be something that is part of the next Careware build, but until that time, it'll be something that you can import the template into your performance measurement module. And what we're going to be distributing next week will be the templates. And along with them will be instructions on how to upload them, similar to when we first created the in-care campaign measures with JPROG and John Milberg's team back in 2011, there was a little bit of instructions there on how to upload them until they were available in future builds.
Perfect. Thank you.
Michael, on the subject of templates, one of my sites asked me yesterday, the example that we have on the end+disparities exchange website, that is a usable template to put your project on. I mean, it's interactive and it can be utilized as a standalone.
Yeah, absolutely.
Yeah.
For those of you who are not familiar, I'm going to do a shameless plug. If you go to end+disparitiesexchange.org, click on resources, click on our calculator friend. You can get the calculator just by clicking here. And voila. Hurry up, you dang thing. Okay, there we go. Yeah, so you can see the data here, and you just enter your data, you know, as you'd like. And the difference is with the unlock tool that, as folks have already mentioned, let me see, I might have to come this way. There are additional red boxes, so you can, you know, make the populations whatever you like. Okay? So that's the difference between those two tools. They're ready to use. They run on the same assumptions. You know, and of course, as I mentioned already, if you have any questions whatsoever, I'm happy to answer them for you.
So while you might be thinking about some questions that you might have regarding the calculator for Michael, what struck me is that there's quite a bit of experience that folks have that are on the call that have been working with teams and groups from planning councils to quality management committees to QI project teams, et cetera. And there's some folks that are also new in their positions. Are there any tips that you would give in terms of what has made your groups or teams successful as they engage in sharing the disparity data, setting priorities, and then through getting ready to implement QI projects? Any tips that you would share with each other in terms of what you found successful?
And Annette?
Yes.
Hey, this is Chuck. Yeah, I just wanted to kind of comment on that. One of the things I think is really important is to create a safe space for, be it the providers. We've had several providers do, you know, QI projects and present them, or consumers are kind of beginning to do some QI work in the TGA. So I think just creating a safe space where, you know, we all realize that quality improvement work is sometimes difficult, and that we can learn a lot by our failures, and to really just create that space where people can kind of present what they're doing without a lot of criticism, with just, you know, with everyone having an open mind. And then, you know, all of us realizing that, hey, if this doesn't work, that, you know, we can learn from that too. Just creating that format, I think, is real important.
And I would echo that as well. This is Judy. I was just going to say that even at the initial stages of no matter what size group it is, if people can just have the conversation, even if they don't have something written up, and they don't have to feel that it has to be a storyboard and a, you know, a fait accompli, you know, some, you know, wonderful looking kind of abstract that they would take to, you know, to exhibit, but that rather, you know, even just trial and error kinds of stories really go a long way.
Okay, anybody else? One of the experiences I had, and I don't think I was expecting it, is that I was with a group that was sharing the results of the data, and the group had a difficult time talking about issues related to race. And I was wondering if anybody else had this situation, and if so, how was it managed?
I think sometimes the conversation morphs into cultural competency, and then that opens up, you know, a little bit more. I know most of my groups are diverse and have, you know, different, you know, groups represented, and you know, there's been frank discussion and all, but I think it also led to discussion about what goes on at the front lines within the clinical programs themselves, and awareness of staff even at that level. so that, you know, there isn't a barrier to discussing. And I've even had, for instance, for my regional group, a transgender person come and address the group and talk about how it is that she would like to be treated when she gets care and so forth. So sometimes you have to start with that and find somebody who's willing to relate a personal story, whether they're part of your team or there's somebody that's willing to come in and lead a discussion about it.
Okay.
Mm-hmm. You know, Nanette, this is Chuck from Memphis. We always, you know, we always operate in kind of a racially charged environment here, I would say. A lot of, and it becomes sometimes uncomfortable when I'm presenting data because it is so overwhelmingly skewed. Basically, the epidemic is in Memphis to African Americans because of our history of, well, for many, many reasons, but anyway, so I would say like 90% of our epidemic is among African Americans. So when I go to someplace and I, you know, start presenting this data, it's like it almost becomes like I'm beating up, especially on, you know, young black MSM. You know, those are always the individuals that have the worst outcomes and, you know, the worst situations and the highest prevalence and the highest incidence, you know, of new infections. And so after a while, you begin like you're just really, you know, kind of beating a dead horse and really unfairly targeting subpopulations. So,
this is Judy. I was just going to say that 3-minute video that Michael mentioned at the beginning is a wonderful, wonderful tool because I think it reaches out and shows that this is what the national perspective is in the general population, and it's with the visual, with the dots and so forth, it's even appropriate for youth that they can see it in red and white, if you will, the known disparities, that it's not just in Memphis or any particular area.
Mm-hmm. Yeah. Yeah, you know, and I have presented the national data as well, and I agree that's a helpful tool. The other thing that's helpful is in the slide set, there's a slide that considers risk behavior among MSMs. I think it's Black, Latino, and white MSM risk behavior. And I think the assumption, and I think a lot of people have this general assumption that, oh, well, if the incidence is higher among Black MSMs, they must be engaging in more risky behaviors. And that particular study, you know, kind of clarifies the point that it's not true, that they're not participating in higher numbers of risky behaviors. So just kind of presenting that kind of information is helpful, I think, just to kind of to clarify what's going on. And then we had one physician who really put it in a great way. He's a young African-American physician here in Memphis. And he said, you know, it seems like people are always picking on us about this, the incidence, I mean, you know, the prevalence of HIV in our community, but it's really a numbers game. If you live in a community with high prevalence, then the likelihood that you're going to, you know, engage in some kind of sexual behavior with someone in that neighborhood, the likelihood of them having HIV is just higher, just because the prevalence is higher in this community. You know, so it's, you know, it's not anything that people are doing wrong or there's something inherently about their, you know, what's going on with their life. It's just kind of a numbers game. So I don't know. Like I said, we're sensitive to these issues, and we really do everything we can to help people understand what's going on.
Yeah, Chuck, thank you for sharing that, because I think that I think we tend to steer away from the notion that data can be emotionally charged. that there's feelings associated with this data. And I think when I first saw this, I was kind of, I wasn't expecting it, I guess, because I was thinking that the group had dealt, had discussed this enough that there wouldn't have been some emotions that were charged with this. So one of the takeaways that I had from that is that if I had to do it again, I would have given more time to the presentation and discussion of the data, because I think that the process was rushed a little bit too much in terms of the time that was given to this. So in retrospect, I would have added more time, and I think I would have asked a question, and I think I'm just thinking about this based on what you were saying, Chuck, is what are the implications of the results for us going forward? And leaving that more as kind of an open-ended for the group members that are there to then get them to start discussing it, so that it kind of takes the pressure off of you as a presenter of the data, and it moves it to the group so that they can begin to own the analysis of it.
I had that experience the first time I presented the calculator and the disparity data. I really didn't give it enough time. That's really crucial for anyone who wants to do this. I totally agree with you. You have to have time for people to kind of digest the information and to talk about it and to kind of feel it out, because we did several items before we presented the data at one meeting, and then we presented the data, and then it was like time to to break the meeting, and people were just, it's like I kind of left everyone feeling miserable. It's kind of like, okay, we didn't even have time to process it and think about, how we might, organize some meaningful interventions to look at these problem areas. So you really do need a good bit of time to process it all.
But what would, and not is by accident, but what's worked for my corner of the world in the state of Florida is that there was a mobilization where we charged the various communities with disparate HIV cases before the tool, with mobilization and them taking ownership. And your physician, your young black physician, was quite right, is that just by the prevalence alone, in some areas in Fort Myers, Florida, the chances of you becoming HIV positive or it's more of an epidemic right there in that community. So I think, charging the community with ownership and having some strategies when the data is presented with mobilization and the community taking ownership would be the second step.
Robert, do you think it would be helpful for the groups that who are attending your meeting to have the data beforehand and to give them a couple questions that they could use to have their group members discuss before they come to the meeting?
And I'm trying to think back because I'm getting kind of elderly. When we mobilizations, it was sort of free flow. It was just it was before this tool, but we were presenting the data, and instead of us telling the community how we wanted ideas from them, so it was more of a free flow back from the community, and they took charge and became very engaged. And I ran the tool, Judy, and don't tell nobody, with the numbers from the agency that I came from before I started working with CAN, and the disparate group were white males, actually. When I stuck in other data, the African-American and Latino populations in the area I came from before I started working with CAN had been addressed, so they were the moderately disparate or very disparate group.
Okay.
My friends, I hate to cut conversation short today. Unfortunately, I do need to end today's office hours so that we can move into our beta test. And the webinar system only lets me have one window open at a time. So I don't know if there's any closing remarks that anyone would like to make. I found today's discussion to be, very interesting, and I'm inspired by the sharing that's happening across all of you on the call. So thank you for everything you do.
Thank you, Michael. Have a good call.
All right.
Thank you to all of you on the phone for sharing. Take care.
Thanks, Nanette.
Thanks.
Bye-bye.
Bye, friends.